Okay. Good morning. Welcome to the maiden voyage of When Is It About the Patient? Our mission here is to educate and hopefully help the average consumer with healthcare concerns, problems, things they don't understand. Between Carrie and myself, we have over 60 years of experience in healthcare. God, that sounds old, doesn't it? Um, uh, and if we don't know the answer, we know where we can get the answer. So that being said, our first episode here today is going to be about hospital billing. A lot of people have a lot of confusion around hospital billing. They don't understand it. They get frustrated when they call the hospital because for whatever reason, they think they need an itemized bill. And they'll call to the hospital and they'll say, I want an itemized bill. And that is so much easier said than done, isn't it, Carrie?
Yep.
I mean, it just, and people don't really understand how hospitals get paid for services from the payers. So I think maybe if we educated people, I think educated consumers become smart consumers. And so instead of just having the mentality of, oh, my insurance will pay for it, at the end of the day, we're all paying for it. You know, as hospital prices go up, and it's a snowball effect is ultimately what it is. And if if we can educate people and make them smarter in healthcare choices and understanding that they're in charge of their own healthcare and how their healthcare dollars are spent, I think it's a step in the right direction. We clearly can't fix all the things that are wrong in healthcare, but I think if we can help educate consumers, it's a step in the right direction. So that
Yeah.
being said, how do hospitals, because I know you understand this, I know how they do it, but I don't know how the bread's sliced. How do they determine what they charge for? Let's see, I'm going into the hospital, I'm going to have my knee replaced. How does a hospital determine what it charges for that?
So, first, I guess I'd like to put a disclaimer out there that yes, we have lots of healthcare experience, but always double check. And if nothing else, maybe with our podcast or with Chris leading this, we'll at least get you to ask the questions you need to ask to providers and the professionals. So, just a
Yes.
disclaimer that
Thank you.
don't take our we're going to try to provide guidance, but we're not the gospel. So we're gonna do our best to help you understand things. So for your question, Chris, on if you were getting a hip replacement, so there's um, for the hospital side. So basically, as you get services done, that's how charges are assigned to you. So if you come in and you get pre-admission testing and you get an EKG, that would be one charge. You get some lab work based on the labs they're going to draw. Those are individual charges, sometimes bundled, sometimes not. We don't need to get into that, but so it's based on the services that are provided. When you get into surgery, it gets a little bit tricky because there's lots of supplies, there's lots of time that goes into a surgery. So when you go into a surgery, you get charged based on 15-minute increments most of the time of being in the OR. Um, we also have some pre time and post time that gets charged. And basically, what that covers is some basic supplies usually under $100 that they're using on you, whether it's needles, scalpels, stitches. You won't see those individually listed out unless they're specific. Um, but that covers the OR time, so the time for the equipment in the OR, the time for the staff, the nursing staff, and all the ancillary staff that help provide services during your surgery, excluding the physician and the anesthesiologist. Those would be billed separately. And then, of course, the implant or any x-rays that they may do while you're in the surgery to make sure they've got things placed right. So it's pretty much based on services that are rendered to you specifically, which makes it very difficult for people to understand why isn't a hip a hip. And that's because of each patient being unique. So someone with more comorbidities, I know I'm stumbling over my words. Comorbidities, that's the word. Someone that is sicker, maybe has congestive heart failure, maybe has diabetes, might require more medication, more supplies, more time in the OR, various things like that, that can cause the variation between me having a hip replaced and Chris having a hip replaced. So it gets kind of tricky. And a lot of people will say, well, I go into a store and I buy an item, it's always the same price. Or I go and get a car, it's always the same price. Because that doesn't vary based on who's driving the car. It's just everything on the car is standard or an add-on. You know exactly what you're paying for. When you go into surgery, there's several unknowns that the physician may run into, and that's why it varies. And so most of the time, hospitals can give a really good ballpark based on experience. You know, they run an aggregate and see high and lows and kind of give you a median range of what to expect. But that's how charges for surgery are done. For other things like an x-ray, it's really based on the test provided and the resources used for that. We don't use film anymore, everything's digital, but there's resources used in that and expenses related to using even digital that gets, and the tech time and the equipment, and that gets calculated into how we charge.
Okay, that's pretty good. Now, if I'm the average consumer, I'm asking the simple question of, okay, so if I have more comorbidities, does that mean that it's going to cost me more at the end of the day when I get my final billing? Am I going to have to pay more than you did for my surgery because I'm sicker?
So it could, but it may not. So, and that's where you get into reimbursement and how the payer pays. So most payers pay what is called on an inpatient, a DRG, or a diagnosis related group. So they get assigned a number based on the services provided to you and the documentation that the physician provides saying everything that he did during the surgery. And when that happens, this number gets assigned, and that's weighted based on the average resources used. And then your payer will pay a rate times that average weight. And so if we're within the norm, and I might be a little sicker than you, Chris, if it's not exceedingly and you didn't use a lot of extra resources and the physician doesn't document that I was 100 times sicker than you, we didn't have that much trouble. I mean, although there's some variations, he may have been in there a little bit longer with me than with you. The reimbursement would be the exact same. The charges that you would see on an itemized bill may be different, but the reimbursement would be the same. And when the reimbursement is calculated, the payment from the payer, when that is calculated, most copays and deductibles are based on that rate and not the total charges. This is a generalization, and that's how most of them work. They are based on the contracted rate the facility has with the payer. So in that instance, we would pay the exact same amount if we had the exact same plan with the same payer, copay or deductible on the final bill that came to us. So I don't know if that's clear or if there's.
No, that helps. So if we had the exact same health insurance with the same, the same plan, our out of pocket at the end of our surgery would be probably the same, because we would have the same deductible, the same copay, although one of us might be farther along in our deductible than the other. So
Correct.
therefore, it would cost the other one a little more. But all things being equal, it would be the same cost. Now, what about physicians? So when the physician sets his price, that's a separate billing.
Correct.
And not every physician charges the same price for that same service.
No, but again, they contract with a payer, and they're paid on what's called CPT code. It's procedural code that they've provided. And when they bill, they have a specific code so they have a specific code that says total hip. And it goes to the payer, and the payer pays based on a fee schedule. Most of the time, again, there's always some variation in contract terms. So a lot of times, again, they will get paid on a fee schedule. And again, if we have the exact same insurance and so on and so forth, just like we discussed, we would probably see the same copay related to that. But again, that is separate billing from the hospital. So that's another thing we could touch on, Chris, is when you go in for a service, how many bills are you going to get?
Exactly. And I think that is a piece of it that kind of ties into the No Surprises Act
Yeah.
and transparency. I think
Yes.
many patients feel that there is a lack of transparency in healthcare billing, that you basically go into the hospital and I'm a guinea pig and I'm stuck here and they're going to do what they're going to do and I'm going to get the bills and I'm going to have to pay, and it just is what it is. And they don't, I know they don't feel any sense of control in that. And
Yep.
in a way, they're right, because when
Yep.
they get there, they do lose that control, because while they may be in a hospital that is on their insurance plan, that doesn't mean that all the hospital providers are on their insurance plan. So I come into the hospital and now I need anesthesia, and that anesthesiologist, he's not on my plan, but that's who the hospital's using, and I didn't have control over that. That
Right.
that was decided by the hospital. I didn't get to decide that. I did decide my doctor, who
Mm-hmm.
usually is the one who drives the place of service, meaning the doctor says, I operate here. This is where you're gonna do your surgery. So if you want surgery by that doctor, you're gonna go to that place. But after that, everything else is out of your control.
Yes. A lot of facilities, though, try to put stipulations in contracts with physicians that provide services at their facilities that they have to be on all the major plans. Now they get to negotiate with the payers themselves too. So there are times when things like this happen, but for the most part, those providers should be on all the plans accepted by the facility. And again, you're right. We've run across that in our time in healthcare as well, where it does not translate that way for whatever reason. The pathologist or the anesthesiologist or the radiologist did not um, get a contract with a specific insurance that is main to the hospital. So we do see that once in a while, but most of the facilities try to put in their contracts with the providers that they have to participate in all the major um, insurance plans.
And
So that's a good point.
I think that's where the No Surprises Act helps the patient,
Yes,
because now
exactly.
technically they are more empowered to go to that provider and say, my insurance paid you, their usual and customary, and I didn't know you were going to be there. I didn't know you were going to be the anesthesiologist or the pathologist that was participating in my care. I had no control over that. You need to accept that assignment and not just balance bill me after you've, applied the payment, because in reality, there's not an insurance company out there now. There used to be, that just pays the fee bill as they get it. If they get a fee bill for $3,000, chances are their allowed amount, which is what they pay, is nowhere near $3,000.
Right.
So that does empower the patient to go back and use the No Surprises Act,
Yep.
to negotiate with that provider who's balance billing them. So I guess that's a good thing.
Yes.
Because before, we know the patients were reliant on us to then go back to that provider and say, hey, look, this patient has Anthem.
Mm-hmm.
And, you're supposed to take Anthem, and clearly you're balance billing the patient. You need to fix that. Correct?
Right.
Yeah. So that's a good thing. That's helpful.
Yep.
And as far as the No Surprises, that's was my basic understanding of it, is for situations like that, when the patient ends up at a facility and there are providers that they don't know. And like radiologist is one that comes to mind, or pathologists, anesthesia, those providers that they don't know, and they get a bill and they're like, who is this guy? Why am I getting a
Mm-hmm.
bill from him? And it confuses them, and understandably so, because it's not anybody they know or have seen. Although usually they've talked to the anesthesiologist, I don't think they connect the dots. So
No. So do you want us to go through for an inpatient, all the different providers that typically touch a patient that would be billing separately?
well, we've hit the three big ones. Are there any others that you can think of?
No, I typically a lot of times let's just go through a patient's journey. Um, if you come by ambulance, you're going to get an ambulance bill.
Correct.
If you come in the ER, typically you're going to get a separate ER physician bill. So you'll get a facility bill for being in the hospital, using the resources, the nursing staff, that all goes into the facility side, and then a separate bill for the physician that treats you. If you get an x-ray, we talked about that, there's a radiologist that reads your x-ray. So typically there's a separate bill for that. If you have some kind of biopsy, that's when pathologists get involved, and there's a separate billing for that. If you have a surgery, we talked about the surgeon and the anesthesiologist. If you don't have a surgery, and even if you do have a surgery and you're in the bed, typically they have physicians called hospitalists that round on you. They come and see you every day and check your chart, make sure you're getting the medication you need and any other therapies you need, any testing you need. You would get a separate bill from them. So there's quite a few people that typically touch an inpatient that are not included in the hospital bill. So I think that would be all of them, don't you think?
Well, and now bringing up the emergency room, it creates another question in my mind. So I'm transported to the emergency room. I've had an injury and whatever I'm transported there for, it needs to be addressed immediately and I need to go into surgery. Does that mean I'm going to get two separate hospital bills?
No, no, that would all roll into one. So from the minute you enter the hospital to the minute you leave the hospital, I'm disrupted. You don't go to the emergency room, go back and come back in. It's all in one stay. That all rolls into one bill. So there are not separate bills. There's separate charges for each service, but not separate billings. And again, if you're an inpatient, a lot of times that gets aggregated to one diagnosis related group that would be paid at a specific rate by a payer.
And then would I get separate bills if I'm admitted because the ER doctor is separate from the hospitalist who is going to round on me during my stay in the hospital?
From the hospital, no, but from the physicians, yes.
Right. So I would now have an emergency room physician fee, and then I
Yes.
would have a hospitalist fee because I went from emergency room to surgery to inpatient.
Yes.
Right. And I think that that's another place where patients also get tripped up is that the confusion over all the different doctor bills that they get.
Right. Right.
Now, what about the doctors? And I know there aren't very many anymore that actually still round on their patients when they are in the hospital. So
So go ahead.
that's few and far between, I realize, but is a hospitalist engaged in the care or does their primary care physician oversee the care?
The primary care would replace the hospitalists in those cases. So yeah, that bill would come from your primary care versus a hospitalist within the
So then
facility.
at that point, the primary care physician is now billing the patient for inpatient care that he is providing while the patient is in the hospital.
Correct. Yep.
And having your primary care doctor round to the hospital will exclude a hospitalist from rounding on you and billing you.
Correct.
How does a hospital discern that at the time of care with the patient?
Typically, if they come in through the ER, the physician groups, primary care groups that round is known to those folks in the hospital. So they get assigned a physician. So they would be assigned to their primary care group as their attending physician, and then hospitalists should be getting lists of the patients they have to round on, and that would be how they would distinguish it.
So now if I'm the patient, my next question is, how does my primary care doctor know I'm there?
They get notified by typically the ER physician, because this is going to get technical and probably too deep, but an ER physician typically cannot admit a person to a hospital. They need to have a attending physician look over what is happening with the patient and decide if that patient needs to be admitted. So in the case of your primary care that rounds at the hospital, they would be contacted and consulted and given all the vital information related to what's happening with you in the emergency room. And then they would determine, yes, my patient needs to be admitted for an inpatient stay so that we can test and monitor and all the things they need to do to get you healthy. And that's how they're notified typically from the ER. If it's a direct admit, where your physician says, yep, I'm going to put you in the hospital tomorrow. Just go to the main registration area and we're going to admit you. Again, on that side, the attending or your primary care would notify the hospital, and that's how the hospital would know who was assigned to you. So,
Okay, that makes sense. Because an emergency room doctor isn't going to admit you because he's not going to be responsible for you once you go beyond the emergency room.
right.
Okay, that makes sense, right? Yeah.
Yep. To me.
At the end of the day, the patients need to understand that there always needs to be, in the hospital world, we call them an attending physician because sometimes that is what they are, an attending physician and or your primary care physician who is responsible for your day-to-day care and overseeing the day-to-day care while you are in that hospital. So that
Correct.
things are not just arbitrarily, the hospital takes care of you, but they don't generate orders for your care. Is that correct?
Right. The physician,
Physicians generate,
based on your signs and symptoms and, everything you're presenting with, your condition, they're the ones that order the care.
right. So the hospital just it facilitates the order and then takes care of you while you're there, but the physician is ultimately overseeing and in charge of the care that you're getting. Okay, in a nutshell.
Yeah.
All right. Well, that makes sense.
Yeah.
Hopefully that clears that up for people that don't understand the path and how the billing is generated once they get into the hospital. So all they know is that when they get home, they start receiving a pile of bills. So
Right.
and that's where the confusion starts to set in, is like, I have a bill for who? I don't know this doctor. And in defense of the patient, you might not remember that doctor's name if it was a hospitalist who came in, and you may not have the same hospitalist every day.
Right.
And then that makes it even more confusing because, okay, I had Dr. Jones and now Dr. Smith saw me and I don't know any of these guys. And that's a complaint that I know that I've heard many times from patients. I'm sure you've heard it. And
Yep.
I don't know them. Why are they billing me? So
Well, too, for those services that you don't even see the physician, like a radiologist reading, you're like, what,
you
or a pathologist, you never see these
yeah,
physicians.
unless you have some kind of interventional procedure with a radiologist, you'll never see them. They're usually, many times in hospitals, they're in a basement in the dark, or away from patient care somewhere in their reading room and looking at the images and dictating the reports. And yeah, so you won't know that guy or girl.
Yep. Correct.
Okay. Well, I think that we've shed some light although I do have another question about a DRG, also known as a diagnosis related group, and how hospitals get paid. So if a payer is paying a hospital according to a DRG, does every payer pay the same amount for that DRG?
Okay, that's a good question. No, they don't. So every facility has the ability to negotiate with the payers reimbursement rates um, based on what they deem would be reasonable to provide services. So um, they do try to probably get relatively close. They want to get, um, they want their costs covered. You know, you can't, unfortunately, healthcare is most of the time nonprofit, and you know, and you're right to receive healthcare. However, these facilities, you know, everyone wants the latest technology, everyone wants the best of the best, and that costs money. Well, if you're not getting paid to cover costs, you're unable to provide certain services at the level you want to provide it. So they negotiate with what we call commercial payers. And what that means is Medicare, you can't negotiate with Medicare. It is what it is for the facilities. Medicaid, same thing. You can't negotiate with Medicaid. So the commercials, your Aetnas, your Anthems, your United Healthcare, that's where they have the ability to negotiate. And just for anyone's information, a lot of times Medicare and Medicaid do not cover the full cost of treating a patient. So you would typically want to negotiate a little bit higher rates from your commercials to kind of make up for the costs you're not covering with these governmental payers. So um, I don't know if that's too much in the weeds, too technical, but so the simple answer is no, they don't all pay the same. And then the complex answer is what I just said. So sorry.
Right. So they're negotiated ahead of time, and the facility slash hospital has a contract with that payer, correct?
Yes.
So the payer cannot arbitrarily decide that, oh, we're overpaying this, we're gonna cut it by $500 and start paying a lesser amount. They have a contracted amount that they've agreed to pay.
Correct. Yep.
So, and we won't get into this now, but we will at some point, that kind of shows the control that the payers have on their side as far as hospital billing and what they can and cannot do.
Yep. Yep. Yeah, that can be a deep discussion there.
Yeah, that'd take a whole hour in itself. But in going forward, we will talk to people from all avenues of healthcare. We will talk
Yes.
to managers, we will talk to nurses, we will talk to people from insurance companies, you know, we will talk to administrators and get all the different perspectives, because everybody has a different knowledge of different things, but I think that in order to tie it all together, you have to talk to people from all the different parts of healthcare to get a good picture. And of course, if people have questions, comments, or concerns, we love to hear that too, and we can try to address that. And as Carrie stated in the beginning, we are not the be all end all. We are trying to educate and help, but always double check.
Yeah, always double check what we're
Yeah,
saying.
you know,
And our experience may be different in
right,
different
right.
parts of the area,
Well,
so
in different parts of the country,
yeah.
some variables are different too. Even like with the DRG reimbursement is not the same everywhere across the country from one payer. They
No,
might pay a facility in California a heck of a lot more than they would pay here in Northwest Ohio
could be.
for a procedure just because of a lot of different variables. So that being said, we're talking our knowledge from here in Northwest Ohio. But I think a lot of the things that we're saying are somewhat standard in most places. And going forward, we will explore all those different things. So at this point, I think to whoever listens to this will maybe overwhelmed. I hope they've learned a few things. And going forward, we will try to address anyone's concerns.
Yep.
So at this point, until next week, when we will cover physician offices, and talk about expectations and how things go there. We'll close this chapter on hospital billing.
All right.